attached to Kaveri Hospital. Welcome, Dr. Madhusudan.
Thank you, sir. Thanks a lot, sir. I've
Yeah,
been here as a PG, sir.
yeah,
So nice to
Back in
yeah.
see you
COVID,
here as a consultant.
I was your examiner, I think. Huh?
I know, sir. I know, sir.
Okay.
So when this series started during the COVID, I was a PG. So I presented in this as a PG, sir.
Thank you. And I welcome on behalf of IAPTNS all the delegates as well as postgraduates from various institutions. So this today's class is fever with breathlessness. I think that we are having eminent faculties, and more than that, our mentor Dr. Agamarnath is intensivist and is having a lot of paper publications also from Stanley Medical College. So for postgraduate per se, almost we are having 900 PG teaching programs in IAP TNSC YouTube channel. I think you can use this opportunity. Almost we are having almost 40,000 subscribers. We are having an IAP TNSC YouTube channel. All teaching program start with basics to high level we are having. So I welcome one and all for this opportunity. Please use this opportunity. On behalf of IAP TNSC, I request all the faculties and life members to vote for Dr. Singarvel sir, who is our national candidate for the central presidential election. Thank you very much. Thank you.
Thank you, Rajendran sir, for the kind words. And not only fever with breathlessness is a very intensive care topic, it is nowadays becomes more of a, it is our bread and butter, because for the past 2 months, I think there has been an increase in the number of children who present with fever and breathlessness. So it's a very day-to-day problem we are seeing. And of course, we are having eminent mentor from Agamarnath and very excellent faculty by Dr. Jacqueline Shah from St. John's. I will never forget St. John's because that was where I did my DNB final exam. It's a very great institute and lovely to see you, Dr. Jacqueline, and thanks.
Same here, ma'am. Thank you.
And of course, Dr. Manoj, I know very well, and he's very interested and keen in academics at even a young age, and it has been very happy to present with him in most of the panels with regard to asthma and allergy. So it's real nice to see you here, Manoj, on this platform.
Thanks a lot.
Yeah. So can I request Dr. Thirumurugan sir, our academic coordinator, to start this? Actually, we are having Stanley Medical College was the one which presented the maximum number of posters, I think, in this Pedicon, Congo Pedicon, and they were very enthusiastic also. So very nice to have you. And I request Thirumurugan sir, if you have joined, to say a few words, then I will hand over to Kritika for the further proceedings.
Thank you, Dr. Narmada. I think it was a wonderful series of PG teaching we have got so far. The 122nd episode, probably the longest running IAP pediatric education program beyond any series. I think it started way back in 2020, I think. Yeah, 2020 when we started, and then it's been going on for quite a long time, and I hope this becomes a long-lasting feature. And I thank Dr. Rajendran sir for continuing this program, of course, with you as the supportive character. And I also thank Dr. Kritika for literally behind my back to make sure that every program happens on time with the best of the faculty. So thank you very much, Dr. Kritika. Over to Dr. Kritika for further proceedings. Thank you.
Kritika, over to you for the very interesting session.
Yes, ma'am. Thank you, ma'am. Thank you, sir. Respected Rajendran sir, respected Balashankar sir, respected Gopal Subramaniam sir, respected Somasundaram sir, dear Narmada ma'am, respected Rajkumar sir, and respected Thirumurugan sir, respected Singaravelu sir. Good evening. I take great pleasure in welcoming you all to the 10th session of this year's IAP PG Masterclass. And today the learners are from Institute of Social Pediatrics, Stanley Medical College, Dr. Meera Krishnan and Dr. Sharma, second year postgraduates, and under the able mentorship of Dr. T.S. Ekamparanath sir, Senior Assistant Professor from Institute of Social Pediatrics, Stanley. And we have two young, dynamic, and very able faculties today to assess them, actually. Dr. Jacqueline Shah from St. John's, Bangalore. She is the consultant pediatric pulmonologist, allergy and sleep medicine specialist. And Dr. Manoj Madhusudan sir, who is a consultant pediatric pulmonologist and sleep medicine specialist from Kaveri Hospital, Trichy. So may I request Meera Krishnan to kindly share the
It's a
PowerPoint?
double-edged sword having the most young persons here. They're
Yeah,
fresh
yes,
from their
ma'am.
postgraduate and they'll ask
Yes.
most number of questions.
Yeah, so
First, because
I'm
you do
eagerly
fun
looking
one.
forward. Okay.
Okay, over to you.
Thank you, ma'am. Thank you, ma'am. Meera?
Good
Yes,
evening,
ma'am.
sir
Your
and
slides are
ma'am.
visible, ma'am.
Good evening,
You
sir
can go to
and ma'am.
slideshow.
I'm very thankful for the opportunity and also very grateful to our Professor Dr. Ekamaranath sir for his mentorship, and also to our director sir, Professor Dr. J. Ganesh sir for this opportunity. May I proceed?
Yes, ma, please.
The case is the chief complains a 1 year, 3-month-old female child who is a second born out of a non-consanguineous marriage coming from Tiruvattur, was brought by her mother, whose reliability is good, to the hospital with the complaints of cold and cough for 1 week, complaints of fever for 1 week, and complaints of breathlessness for the past 1 day. History of presenting illness. The child was apparently normal until 1 week back, which she developed a running nose, which was for 1 week of duration. She had mucoid discharge, white in color, and it was not foul smelling. There was history of cough for 1 week, which was wet cough. There was one history of post-excessive vomitation. It was not blood. No hydration, and there were no relieving factors for cough. There was history of noisy breathing. There was history of cough for the intermittent, not associated with chills or rigor, and it was relieved with medications. And active, the child was active during interfebrile period. On day 3 of illness, the child was taken to a private clinic and was treated with oral antibiotics and paracetamol. There was history of breathlessness for the past 2 days, onset and progressive, associated with chest retractions. There were no specific aggravating or relieving factors to the breathlessness. There was history of lethargy for the past 1 day. History of decreased oral food intake was also there. There was no history of ear discharge or tugging at the ear. There was no history of skin rashes. There was history of foreign body aspiration. There was no history of a bluish disposition of tongue on fingertips. There was no history of suggestive of congestive cardiac failure. There was no history of loose stools. And no history of decreased urine output.
Can we stop at this
Past
point
history?
and go back to the history, if it's okay?
Yes, ma'am.
Okay. So, how do you describe cough in children? What are the things you should ask for?
Ma'am, first is duration of the cough, onset.
Yeah. Yeah.
And then if it's a dry cough or wet cough.
Yes.
Also, if there is any postural or diurnal variations, and if there
Yes.
are any aggravating or relieving factors.
Yes. And how do you tell if it is? How do you explain the onset? Either it is sudden in onset or it is gradual in onset. And is it
Gradual
acute,
onset, yes, ma'am.
subacute, or chronic? So anything
Or
less
chronic.
than 3 weeks will be acute cough.
3 weeks
Between
is acute,
3
ma'am.
to 8 weeks will be subacute.
8 weeks is subacute. More than 8 weeks is chronic,
Yes.
ma'am.
Can you give some examples for acute cough?
Acute cough could be any airway is the most important factor when we talk about cough, because that is where all the cough receptors are. So any acute cough could be asthma, hyperreactive airway disease, and a foreign body which the child might have aspirated.
Yes, very good.
URIs and LRIs, all of them will present with an acute cough. And bronchiolitis, most importantly, in the children less than 2 years of age.
Okay. And subacute?
Subacute could be a foreign body that's been aspirated and been stuck in a smaller airway. GERD could also be a cause, ma'am. And
mostly post-viral bronchiolitis.
Post-viral
These go
bronchiolitis.
subacute. And chronic cough?
Chronic cough.
Tuberculosis.
Tuberculosis.
Yeah.
Could be a cause.
Yes. So it is infectious causes like tuberculosis or protracted bacterial
Bacterial
bronchitis.
infections.
You have bronchiectasis. You can have
Bronchiectasis
retained
or
foreign body.
bodies, yes, ma'am.
You can
And,
have GERD. Or you can
and
have
any
disorders of
dyskinesia, like cystic fibrosis, primary ciliary dyskinesia.
Yes, okay, very good. What about diurnal variation?
Ma'am, diurnal variation, usually if the child is telling that if the mother is describing that the cough is while the child lies down, then we should immediately after the child lies down, we should think of GERD
Very
in
good.
that postural variation. If
Yes.
the child is waking up from sleep and then coughing, we should think of asthma. And if the child is waking up in the morning and then having a productive cough, we should think of suppurative lung disorders.
Okay. Or a post-nasal drip.
Or as a post-nasal drip.
Yes. Yes. Okay. 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 Please continue.
I would like to ask just one question. Can you go back to the previous slide? So you nicely summed up the history. So you mentioned that on day 3, the child was taken to a private clinic where child was started on oral antibiotics.
Yes, sir.
Okay. So what would you have done in that scenario? A child comes to you on day 3 with fever, cough, active when afebrile, playful when afebrile. What would you have done?
Sir, this seems like it's a with viral prodrome and then cough and then fever, sir. At that time, if the child is active, all we have to do is symptomatic management, sir. Rather than start the child on antibiotics.
Okay. You would have just given paracetamol. Any warning signs that you would have explained to the parent?
Sir, chest retractions, breathlessness, lethargy, refusal of feeds. All of these would be warning signs that we would explain to the parents and ask them to come immediately if any of them were present.
Sure. Right.
Your next complaint was breathlessness.
Yes, ma'am.
Yeah. What would you like to ask for in breathlessness?
Ma'am, onset of breathlessness again is a gradual onset or in sudden onset. Sudden onset.
So it's
like
only since 1 or 2 days.
1 or 2 days, ma'am.
Yeah.
And if it is progressing or if it is, or if there are any aggravating and relieving factors, also if the breathlessness is associated, if there is any postural variation in the breathlessness, and also if the breathlessness is associated with chest retractions, ma'am.
Okay. You should also ask for association with fever, association with stridor, so that you can come to the cause of
Any noisy
breathlessness.
breathing, ma'am.
Yeah.
Yes, ma'am. I'll ask for noisy breathing.
So causes of breathlessness, it can be respiratory, it can be cardiac, it can be metabolic,
it can be metabolic.
CNS.
Encephalopathy, CNS.
Okay. Okay. Please proceed. So why did you ask for all this negative history?
Ma'am, lethargy, decreased oral intake because of the warning signs, ma'am. It can suggest that the complications, the child is moving towards complicated pneumonia or the child is having hypoxia, which can also present like lethargy and refusal of feeds, irritability. And then ear discharge and tugging at the ear. URA can get complicated with otitis media, ma'am. So the child, a child which is 1 year old would probably just tug at the ear or keep crying, incessant cry would be there. Or there might be an ear discharge, ma'am. And
So mainly
skin rash.
if it is upper respiratory or lower respiratory first.
Lower respiratory tract.
Okay. After that, you want to know if there is any other system involved. So it's nice if you can put the systematic complaints together, like GI symptoms, CVS symptoms, and then you come to CNS symptoms to look for complications and to look for associated symptoms. Okay.
Should I elaborate the rest of the history? Or should I just...
I think you can go forward.
Okay. Past history. No history of similar illness in the past requiring hospitalization. There is no history of previous OP nebulizations, no history of recurrent respiratory tract infections, and no history of previous exanthematous fever. The child is not a known case of congenital heart disease or seizure disorder.
Okay. What are recurrent respiratory tract infections?
Ma'am, more than 2 infections in the respiratory tract infections in the span of 1 year, and there should have been a radiological and clinical clearance between the 2 episodes, or more than 3 episodes in any given period of time.
So that is recurrent pneumonia. What about recurrent upper respiratory? How many are common in a year?
Around 4 to 6 are common in a year, ma'am. The child should have had treated. The child should have been treated in the hospital, ma'am, for these, for us to call them as a recurrent respiratory tract hospital.
So there is no history of recurrent infections at all.
Yes,
okay.
Antenatal history. The mother was married at the age of 21 years. She conceived at 24 years of age, was registered and immunized. Iron folic acid tablets were taken. There is no history of rash, fever with rash or lymphadenopathy, no history of gestational diabetes mellitus, no history of gestational hypertension, hypothyroidism, or bleeding baby. Quickening was felt at 5th month of gestational age, and fetal movements were well perceived. Anomaly scan was done as 21 weeks of gestational age and found to be normal. Liker was said to be adequate. Natal history, the child was a full-term normal vaginal delivery, which was conducted in an institutional RSRM, to be particular, and child cried at birth, and the birth weight was 2.8 kgs. Neonatal history, there was no history of NICU admissions.
Okay.
Developmental history, gross motor, she walks without support, she scribbles, and social and adaptive, she has jargon speech, and she speaks 1 to 2 words with meaning. She has attained all the age-appropriate milestones, and the development quotient is 100% across all domains. Diet history, the child was exclusively breastfed for 1 week, and after that she was started on formula feeds. Now the child consumes a mixed diet, and the diet history was taken via the 24-hour recall method before the illness started, and she has a calorie deficit of 150 kilocalories per day and a protein deficit of 6 grams per day.
Okay.
Immunization history, the child is immunized up to age as per national immunization schedule, and the last vaccine was at 10 months of age, which was the MR and the PCV booster, and no additional vaccines were given. Family history, this is a non-consanguineous marriage. The parents have 2 children, and she is the second child. There is no significant family history in the form of similar complaints in the family or any allergy, atopy, or asthma in the family members. Socioeconomic history, the child lives in a pakka house with 2 rooms. There is no overcrowding. They use canned water for cooking and drinking and LPG gas cylinder for cooking. No history of passive smoke inhalation and no pets in the house. And she belongs to lower socioeconomic status according to the modified service scale.
Okay.
There is no known allergies or any food or drug substances. A contact history, there is no history of contact with any open case of tuberculosis. Summary, a 1-year, 3-month-old, developmentally normal and fully immunized female child who is a second born out of a non-consanguineous marriage was brought with the complaints of cold and cough and high-grade fever for the past 1 week and breathlessness for the past 2 days. She was treated with oral antibiotics and symptomatic management outside, and she has insignificant birth and past and family history. The system involved is a respiratory system, probably an acute respiratory tract illness, which is an upper followed by a lower respiratory tract, probably due to an infectious cause. And right now, I would like to offer a differential diagnosis of first would be a viral bronchiolitis and also viral pneumonia.
Why do you say it's viral pneumonia?
Ma'am, from the history, the presentation was first running nose, coryza, followed by cough and fever, which probably points towards a viral illness. Also, initially, the child was fine. It was not a very toxic child. Breathlessness developed later, ma'am.
Okay.
So from the history, you can point more towards a viral illness.
Okay.
But there's been a fever for almost 7 days, right? And the child
this is the
came
7th day.
class and is still febrile. How can you still have viral bronchiolitis as your first differential? So bronchiolitis, how many bronchiolitis has fever for 7 days? See, I agree it could have been a bronchiolitis to start with.
It
So now when
complicated
you,
with a secondary bacterial infection or
exactly,
a protracted infection.
Exactly. So you're presenting the child at 7 days of illness.
Yes, sir.
The child who's been having continuous high-grade fevers, the child who's fast breathing now. So
Yes,
I don't think bronchiolitis can be your first diagnosis.
Yes, sir.
You are right at 3 days of age. I mean, 3 days of illness when the child came with just fevers, active, some URI, some cough. Okay, now viral is not your first differential.
Okay, probably a secondary bacterial.
Okay, also there's history
Probably
of
bacterial.
lethargy, decreased intake.
Yes, sir. For the past
Okay,
2
so all
days.
that indicates that the child is sick.
Yes, sir. Yes,
Okay, more
but
bacteria.
also in a secondary bacterial, usually there is a period of improvement before the child deteriorates.
See, secondary or primary bacterial, don't confuse with that, okay? You have a child who has 7 days of fever, cough, fast breathing, lethargic, poor intake. This points towards a bacterial picture.
Okay, sir.
Your first differential is a bacterial pneumonia or a community acquired pneumonia.
Yes, sir.
Be it primary or secondary, that is something you need to, I mean, maybe you should have followed the entire child throughout the course to comment on that. But looking at it, the child now has a bacterial respiratory infection.
Yes, sir.
Okay. A lower respiratory infection, which is
Lower
bacterial.
Okay, proceed.
General examination. On examination, the child was verbal, afebrile, Pallor was present over the conjunctiva, palms, and the palmar creases were normal. No cyanosis, no clubbing, no icterus, no significant lymphadenopathy, and no edema. Vital signs, the pulse rate was 130 beats per minute, which was regular in rhythm, normal volume, no specific character, no radial or radiofemoral delay was there. All peripheral pulses were felt. The blood pressure was 80 bar 50 mm of Hg, which was measured in the right upper limb in supine position. The respiratory rate was 64 per minute, which was an abdominothoracic type of respiration. The temperature recorded was 98.4 degree Fahrenheit, and saturation was 92% under room air and 98% with oxygen. The pulse volume was 3+ in the femoral and 2+ in dorsalis pedis. And the CRT, the capillary refill time, was less than 3 seconds.
Can we go back to the general physical examination? Okay, continue. Okay.
Head to foot examination. The head was normal in shape and size. There was no dysmorphic facies. Chest was normal in shape and there was no bony deformities. Abdominal and genitalia were also normal. The limbs had healed impetigo scars which were present over both lower limbs. BCG scar was present and there were no external markers of TB. There were no skin rashes which were seen at present. Anthropometry. The child's weight for height was from -1 to -2 standard deviation, which was normal for that age. Mid-arm circumference was also from -1 to -2 standard deviation, which was normal. Examination of the upper respiratory system. Nose.
Mid-arm is how much? 12.5.
Yes.
Is it normal?
It's the border of normal.
Go back. So above 13.5 is normal. No? So mild malnutrition. You can take it as mild. Okay.
Nose. Mild flaring was present, anterior nares and vestibule. There was dry discharge present, which was scanty and whitish in color. There was no foul smelling. No deviated nasal septum, no polyp. Inferior turbinate was not swollen or hypertrophied. The external ear was normal and there was no discharge seen. In the external auditory meatus, bilaterally wax was present. Tympanic membrane was not visualized. There was no tragal tenderness. Oral cavity and throat, oral mucosa and gums were normal. Anterior tonsillar pillar was visualized, which was normal. Posterior pharynx could not be visualized.
Okay.
Respiratory system. Inspection, the trachea appeared to be in midline and the chest wall shape was normal and symmetrical. There was no chest wall deformity. Chest wall movements were equal with respiration. The work of breathing was increased. Both subcostal and intercostal retractions were present. There were no scars, sinuses, or dilated veins.
Okay, I would just like to tell, when you're talking about respiratory system, start with upper respiratory, then go to lower respiratory. In upper respiratory, mention the ears, nose, and the throat.
Yes, ma'am.
Okay, and then when you come to lower respiratory, first you talk about the rate, the type of respiration. Are there any retractions or not? So how is the respiratory effort? Is there any audible stridor, or is there some noisy breathing? Is there some audible wheeze that you're able to hear? Is there a grunt? Those things should be added initially as you see the child. Okay, next in the nose, you have spoken about, so mention each thing. Okay, talk about congestion, because that's the most common thing you see.
Yes,
any nasal discharge, any nasal flaring. Okay, which what does nasal flaring mean?
Work of breathing is increased, ma'am.
It's increased, yeah. Okay, and is there any foreign body in the nose? Is there any bleeding? Okay,
Yes,
and you've written swollen or hypertrophied inferior turbinates. Okay, with pale mucosa, maybe in a bigger child.
Allergic asthma
Yeah.
would
And also mention sinuses in a bigger child, sinus tenderness.
Yes, sinuses.
Okay.
Sinus
And then when you come to the throat, mention the teeth, the oral hygiene, dental caries are present or not, the posterior pharyngeal wall, the tonsils. Okay. Then when you come to the lower respiratory tract, you can shift the slide. Yeah. First you talk about the trachea, if it is in the midline or not. Then you talk about the chest wall. What are the shapes you know of?
Ma'am, a barrel-shaped chest wall could be present in
maybe in an older
asthmatic child.
Okay, then
a younger child could have deformities like pes excavatum or pectus carinatum.
Okay. Then you have to also comment on the spine. If there's a kyphosis or a scoliosis.
Kyphosis or scoliosis, ma'am, spine. The spine
you have to mention about the spine. Why is it so important?
Even spinal deformities can cause respiratory distress, and also they will cause shifting of trachea, and while our examination will
It
also
can cause
change
kind of restrictive lung disease.
restrictive lung diseases.
Okay, fine. Then what about Harrison-Selkers, rickety rosary?
Ma'am,
So
if there's a
mention
chronic
all that.
respiratory distress,
Yes,
the
yes.
child might have Harrison-Selkers, also points
Yes.
towards a vitamin D deficiency.
Yeah, okay, okay. Then work of breathing, okay, subcostal and intercostal retractions, scar sinuses and dilated veins, okay. And movements you have not mentioned, okay, mentioned. Okay.
Palpation, there was no warmth or tenderness. The trachea was in midline. Apical impulse was felt at the fourth intercostal space in the left fourth intercostal space in the mid-clavicular line. The chest expansion at the level of nipple was 1 centimeter. It was bilaterally symmetrical, and the thoracic ratio was 0.7. A vocal fremitus was increased over the right infraclavicular and supraclavicular regions. Percussion,
Can
the
you
child
name
did
some
not
conditions
cooperate
where
with the-
trachea shifted to the opposite side?
Ma'am, pneumothorax.
Okay, anything
or,
with a
pleural
collection
effusion,
underneath. It
both
can
of
be
these.
fluid, it can be air.
Yes.
So pleural effusion, pneumothorax
It will push
will shift the trachea to the opposite side. And what pulls the trachea to the same side?
collapse.
Or a fibrosis will pull. Yes.
Atelectasis, fibrosis, everything will pull.
Okay. Vocal fremitus. How did you check for vocal fremitus?
Ma'am, while the child was crying, we place our ulnar bottle. While the child was crying, we place our ulnar bottle of the hand and compare it to each side in all the 9 areas. We compare on both left and right
Okay.
side.
When is it
And we
increased?
can feel for the vibrations. In consolidation, ma'am.
Okay. Fine. In consolidation. When is it decreased?
In pleural effusion.
Yeah, same thing. Anything, any collection
Pneumothorax,
that's coming
any-
between your hand and the palpating
lung.
lung. Any collection that comes in between
Lung.
will reduce the fremitus. Okay. Then movements of the chest wall. So just observe the movements and you see if bilaterally the movements are equal or not. Usually the side with the pathology will have decreased movements. Any kind of pathology, effusion, pneumothorax, consolidation, anything will have decreased movements on that side of the chest wall. So look for movements.
Yes,
Okay. And tenderness, you have not mentioned tenderness. Any intercostal tenderness? Okay.
Mention tenderness.
Okay, okay.
Percussion, the child did not cooperate with the examination, so it could not be tested. And auscultation, bilateral
What
air
is the
entry was
normal
equal.
percussion note you get in a lung field?
So, ma'am, normally we'll get a resonant note. If it's hyporesonant, we should think about pneumothorax. If it's impaired, a dull note, we should think about consolidation. And if it is a stony dull, then we can think about pleural effusion.
Okay, okay. And auscultation?
Auscultation, ma'am. Bilateral air entry was equal. Bronchial breath sounds were heard over the right infraclavicular, right axillary, and the right suprascapular region, which was loudest in the right infraclavicular region. Right-sided diffuse clefts were present, ma'am.
Okay, now how do you localize the lesion in a respiratory system? How do you know which is the upper lobe? How do you know if upper lobe, middle, or lower lobe is involved?
Ma'am, we can use the surface markings of the lung, ma'am. On the right side, the lung starts around 1 inch above the right clavicle.
That is your apex.
Yes, ma'am, apex of the lung. In the parasternal line, it's the fourth intercostal space. And then in the mid-clavicular line, it's the 6th. In the mid-axillary line, it's the 8th. And at the back, it's the 10th, 6, 8, and 10.
That is for the base of the lung.
Base of the lung, ma'am.
6, 8, and 10. 2
ma'am,
spaces more than that will be the pleura.
The pleura, ma'am. And we can also see the oblique fissure and the transverse fissure, ma'am. The oblique fissure, which is in the mid-axillary line, starts at the ma'am, here, sorry, in the mid-clavicular line, 6th intercostal space to 5th intercostal space.
See, from the back, go from the T2 spine on the back, trace the curve forwards up to the 6th rib in the mid-clavicular line.
Mid-clavicular line, ma'am. In the mid-axillary line, the 5th space.
Yes,
and
that is your major fissure.
Major fissure. And ma'am, the transverse fissure would be in the 5th in the mid-clavicular, in the mid-axillary line to the 4th in the mid-clavicular line.
Okay. So anteriorly, most of it is your upper lobe, right upper lobe, and whole of the middle lobe.
Middle lobe.
And posteriorly, you have most of the lower lobe.
Lower lobe. Yes,
okay, so right
and
has
in the
3
axilla, we
and
have
left
all the
has
3
2.
lobes.
Yeah.
In the axilla, you can listen to all the 3 lobes.
Okay. Okay. So based on your findings now, where is the lesion? Where is the infection according to you?
Ma'am, right upper lobe is...
Okay.
seems to be more involved, but right-sided diffuse creps were there, so it feels most of the bronchial breath sounds were heard and the vocal phlegmatis was also increased in the right upper lobe area. So it points towards a consolidation in the right upper lobe, but diffuse breath crepitations were also heard in the right entire lung. So it might also be a spillover infection or a more diffuse involvement, ma'am, with the major consolidation being in the right upper lobe.
Okay.
See, crepitations just means there is some secretions in the airway.
Secretions
So
in the airway.
in a child as young as 1 year with a pneumonia where you've been treating with antibiotics and all, you can have some crepitations here and there. That doesn't mean that lobe is particularly involved. So there could be some secretions in the right main bronchus which has spilled over, and that is causing some conducted crepitations over the lower. So from whatever, I mean, as you beautifully explained in these slides and answered as well, the child probably has a consolidation that is involving the right upper lobe. It's a lobar pneumonia from whatever you're saying.
Yes, sir.
Sure.
Other system, cardiovascular system, both the S1 and S2 were present. There was no murmur. Abdomen
May
was
I ask
soft.
one question, Mira? Ma'am, may I
Yes,
ask
ma'am.
one question?
Yes, ma'am.
What is the thoracic ratio, ma'am?
Ma'am, thoracic ratio is in this child is 0.7, ma'am. It is the ratio of the AP diameter to the transverse diameter, ma'am. It gives us an idea about the chest expansion, ma'am. And also
Okay, so
in
80
older
is to
children like
transverse ratio.
asthma who would have a barrel-shaped chest, we can see that ratio has been altered because of chronic hyperinflation.
Okay, ma'am.
Abdomen was soft,
Please
not
proceed.
distended and non-tender. Liver span was 6 centimeter and there was no organomegaly. The central nervous system, the tone and posture were normal. The power was 5 on 5 in all the four limbs, and bilaterally pupils were equally reactive to light, and the AF was closed in this child. Summary, a 1 year, 3-month-old, developmentally normal and fully immunized female child who was a second born out of a non-consanguineous marriage, who was brought with the complaints of cough and cold and high-grade fever for the past 1 week and breathlessness for the past 2 days, treated outside with oral antibiotics with insignificant birth, past and family history. On examination, the child was verbal, there was pallor present, and the respiratory system examination showed an increased respiratory rate and increased work of breathing, along with vocal and tactile phlegmatis being increased in the right supraclavicular and infraclavicular regions, bronchial breath sounds over the right suprascapular, infraclavicular, and axillary regions, with bilateral creps were present, and other systems were normal. A provisional diagnosis, the right upper lobar pneumonia with anemia in this child, and possibly bacterial etiology, and our secondary diagnosis would have been a viral etiology.
Exactly. So what virus can present? I mean, what is the most common virus that usually presents with a lobar consolidation? Generally, viruses do not involve a single lobe. It is bilateral.
So even influenza and adenovirus can present like that, sir.
Exactly. So a couple of years back, we had an epidemic of adenoviruses. So those children have prolonged fevers, they are toxic, they have lobar pneumonias.
Yes, sir.
So that is the only virus which can come with this sort of presentation. From whatever you presented, this is looking more like a community-acquired pneumonia. Viral is definitely not the first diagnosis.
First diagnosis, sir.
Sure.
What bacterial etiology are you thinking about in this age group?
Age group is 1 year, so
Pneumococcus.
Pneumococcus, Haemophilus influenza, Staph aureus.
Okay, what do you think, according to the history and examination, which bacteria could have been? What do you think?
Pneumococcal, but the child is more common, ma'am, but the child is vaccinated. Staphylococcal can also present because a single lobe is involved. It could have been a complicated pneumonia the child could have had.
Okay.
Would you think about atypical infections, mycoplasma?
So the child is just 1 year, 3 months old, sir. Mycoplasma is more common, more than 5 years of age, sir.
Yeah, so but it can occur even between 1 to 5 years. So what are the features which should suggest atypical pneumonias?
A walking pneumonia, the child would initially be fine. That won't be so toxic, and it will start as a viral prodrome. It will mimic a viral infection in the beginning, and then the child would have the more sick manifestations.
Which is what happened in your child, right?
It is what happened in our child.
Sure. See, one other thing is that although atypical pneumonias are typically more than 5 years, especially if there is a sibling who's going to school, all the
Yes.
more reason atypical should be placed upfront.
Yes.
If there's a sibling, any child nearby who's going to school who's also unwell recently,
Yes, sir.
atypical would rather be more than pneumococcal. Okay.
Yes.
I mean, not at this point. Right
Yes.
now, the child is tachypneic hypoxic, fits the textbook definition of a typical bacterial pneumonia. Maybe at 5 days before tachypnea develops, atypical should be slightly higher up on the chart.
Yes.
What are the other features that would suggest atypical pneumonia?
With mycoplasma,
See, there
there
is
might be a
anemia also,
rash.
no? There can be hemolytic anemia, there can be
Hemolytic uremic
rashes,
syndrome,
joint
which is
pain,
joint pain, arthralgia,
multi-system involved.
multi-symptoms.
Okay.
Anemia, thrombocytopenia, all of this can present with mycoplasma. Hemolytic uremic syndrome, arthralgia, joint pain.
It can also present like SJS, mimic SJS, like rashes can also be
Yeah,
present.
yeah, yes. Okay.
The investigations that we would suggest for this child to be taken is the CBC, a C-reactive protein.
I have
and a
one
protein
question,
protein.
Meera.
Yes,
I
ma'am.
have one question. How did you note the liver span?
Ma'am, liver span, while the child was supine, first we did a percussion where we start from the second intercostal space and in the mid-clavicular line until we note the area of dullness, and then from the method of palpation, ma'am, from below upwards to see the
Okay, very
point
good. But
of.
you told the child was not cooperative for percussion.
Ma'am, the
You
child
have
is not cooperative.
contradictory statement, right? It is better avoid those statements. That's all.
Okay.
Okay. So
See,
you have
always when you always
Yes,
when you
ma'am, please,
approach the child, please just make sure that the child is comfortable. Examine
Yes.
in the most comfortable position, maybe the mother's lap.
Mother's lap.
First, befriend the child, and then you go forward for the examination. Only when the child is comfortable with you, she's going to allow you for examination.
yeah, you shouldn't contradict your own statement, okay? பொய் சொன்னா கரெக்டா சொல்லிட்டே இருக்கணும். If you're going to tell a lie, you have to maintain it. Yeah, please proceed.
The other investigations that can be done in this child are a complete blood count, a C-reactive protein, and a procalcitonin, blood culture and sensitivity, chest X-ray, and a throat swab.
What are you doing? What are you going to do in throat swab? Culture, or you planning any PCR?
Sir, since my initial was viral, so probably a PCR. And even if you are looking at mycoplasma, sir, PCR, sir.
Makes sense. That is what I want to do. Because throat swab culture doesn't have much of a role in a bacterial
Yes.
pneumonia. PCR, yeah.
The investigations of this child, the hemoglobin was constantly low, around 7 to 6, and the total count was elevated. The platelet was in the normal range. The RFT and electrolytes were normal. LFT was also normal with albumin, only the albumin was low. The peripheral smear showed a dimorphic anemia with a reticulocyte count of 0.5. There was no growth in blood culture, and the CRP was elevated. Initially was mildly elevated. As the child progressed, the course progressed, the CRP was elevated. This is the X-ray of this
What
child.
treatment was the child on? So I agree you did all these investigations. What did you start the child on when the child initially presented?
So initially we started the child on ceftriaxone, sir.
Only ceftriaxone.
Only ceftriaxone,
Sure.
along with oseltamivir to cover the viral part also, sir.
Sure.
But then this is the X-ray of the child, sir.
No, just a minute. Can you go back to the previous slide? The other one, the one that has the CRP. So I assume the child came to you on 27th, right?
Yes, sir.
So you had started ceftriaxone and oseltamivir on the 27th.
Yes, sir.
So, I
Yes,
mean,
sir.
you're more or less looking at a bacterial pneumonia. I mean,
Yes, sir.
bacterial is obviously higher up on the chart, especially after seeing the X-ray. You start ceftriaxone, CRP is 25, there's consolidation. How long will you wait for defervescence? Or how long will you wait?
48 hours.
So at 48 hours, do you have the temperature chart or something, or can you tell me what happened to the fevers?
So initially the child was improving, sir. I put the course of the illness, sir. I've discussed the course of illness.
You can just tell me. I mean, I just
Okay.
want to know
Sir, the
your
child,
thought process.
initially the child was improving, sir. And
Improving in the sense, was the child afebrile at 48 hours?
sir, fever spikes had come down, sir. The temperature initially was high grade continuous, and then it became a temperature spike, one in the morning, one in the night, sir.
But the child was still febrile, right?
The child was still febrile, but the frequency of the fever and the intensity, the initial temperatures recorded were around 103, 104, sir. But then the rest came down to 100 and 101, 100 point something, like, sir, the temperature and the frequency. And also
So
the
at
child
what-
was clinically improving, sir.
So at 48 hours, you decided to continue the same. Am I right?
Yes, sir. Initially, we.
You would discuss that in the future, is it?
Yes.
In the next slides, is it?
Yes, sir.
Okay, please go on.
So this is the initial X-ray of the child. It's a plain X-ray, AP view, or plain X-ray chest, AP view. It is an expiratory film. That is why the expansion is less. Also, it is rotated towards the right. And there is, trachea seems to be in the midline. There is a right upper lobe and middle lobe consolidation, and there is also right lower lobe haziness that is seen.
How do you define lobes in an X-ray? How do you say the right middle lobe is involved? For example, how do you say
X-ray
upper,
is,
lower, or middle lobe based on the X-ray?
So usually in X-ray, we'll say comment about the zones, sir. But if
Zones.
paracardiac is involved, we'll say that the middle lobe is
involved.
involved. And if the right diaphragm is also hazy with the paracardiac involvement, we'll say like it is
Lower
lower
lobe
lobe
is also
involvement.
Exactly. So that is called the silhouette. That is called the silhouette sign. So if your mediastinum, if you're not able to see the mediastinum properly, the upper mediastinum, it is the upper lobe. The right cardiac border, you're not able to differentiate properly, it's a middle lobe. And if it's the right, diaphragm that you're not able to see properly, it is the lower lobe. So based on this, in this X-ray, right heart border is more or less seen, but there is some sort of haziness.
Haziness, it is not clear.
And the diaphragmatic, maybe, but it's predominantly right upper.
Upper lobe.
You can't confidently comment about the middle lobe pneumonia.
Yes.
Okay.
The course in the hospital, the child was admitted to PSCU and started on O2 under HFNC. IV antibiotics, so ceftriaxone was started. In view of persistent respiratory distress and fever spikes, the child's antibiotics were escalated. And then on day 2, and then the child showed
what would you
improvement on
escalate the antibiotics to? So that was my question. So on day 2, although the child was better, the child was still spiking fevers. So a pneumonia case where you started good antibiotics to begin with, at 48 hours, not settling. What would be your thought process? Why would a child, despite starting proper antibiotics, still be spiking fevers?
So first and foremost, you have to think of that the organism is not sensitive to the antibiotic we are giving. So we consider, and we should also give staff coverage because it's a community acquired situation. So we shifted to vancomycin, sir, to cover both MRSA also.
What other reason would be there for a child who's not responding?
Inadequate dose, inadequate drug.
That I assume you would have taken care, right?
Yes, sir.
Child is in the hospital.
So what are the causes for not improvement? What are the causes? Or you want to repeat
Or
an
it
X-ray?
can be a viral.
Sir, complicated pneumonia like empyema.
Empyema.
So you should think of complications if it's not improving.
Exactly. It is the other way around, okay? I would say most of the community-acquired pneumonias that you're going to see is going to be pneumococcus. Okay. So if a child at 48 hours is not responding, antibiotics shouldn't be the first thing that should be tweaked. You have to look for complications. Okay. What are the complications that you're expecting in a child with a community-acquired pneumonia?
Complicated pleural effusion, empyema, lung abscess can occur, and other extrapulmonary complications
like septicemia can occur, sir.
Exactly. So in this child, child is hemodynamically stable, responding somewhat, though the child is not afebrile. Okay. And you are telling the child you are able to slowly wean off HFNC, right? So at 48 hours, when you are evaluating, what investigation would you first order or do? What would you do at 48 hours? Child is still febrile, a bit better, definitely not septic. So what would you do? What would your evaluation be? So before jumping the gun on antibiotics, I would do a certain things to see if I'm on the right track. What would that be?
The inflammatory markers we can recheck to see if there is any change, if they're decreasing trend.
And
So the CBC showing a decreasing total count might also help in the same
You're
way.
thinking of complications, no? You only
So
told the
X-ray, a repeat
complications.
X-ray and an ultrasound lung.
Which is
exactly,
better?
Ultrasound lung, which will show you any
exactly,
loculations or septations if there is empyema.
exactly. So at
And
48
effusion
hours,
also.
so at presentation, or you take at day 7 when you at first seen, this looks more or less like a garden variety community acquired pneumonia. A 1.5-year-old, persisting fevers, fast breathing, all the telltale signs are there. Okay, you start on good antibiotics. At 48 hours, if the child is not responding, your first thought should be, is it a complicated pneumonia? Because you've looked at other things, this looks like a community acquired pneumonia. Good antibiotics, not proper response, your first thing is a complication. Once you've ruled out a complication with an ultrasound or maybe an X-ray, that is when you start thinking about other things. That is when you start thinking about staph cover, those sort of things. Okay. And in the recent years, although typically, I mean, whenever I was doing my PG, atypical pneumonia, the textbook definition is that it will be a walking pneumonia. Child will be completely well, but X-ray would be bad. Okay. But of recent years, we've even seen significant effusions. We've seen necrotic pneumonias with mycoplasma. So in view of the recent events, I would think of mycoplasma also in my differentials at this point of time, since the child is not responding. So I would rather, instead of adding vancomycin, I mean, this is a personal viewpoint, I would add azithromycin,
Macrolides. Yeah.
macrolides.
Macrolides.
Because the child is not worsening. If you're thinking MRSA on day 9, child would have worsened.
Yes.
Not this slow improvement. That is not MRSA typical. Sure, go on.
And on day 5 of hospitalization, the child was weaned off to O2 under NRM in view of decreasing respiratory distress. And in view of persistent respiratory distress, which was requiring O2 support, an echo also was done. And it showed an anechoic cyst, which was adjacent to the right atrium. And after that, we immediately followed up with an ultrasound chest, which showed multiloculated pleural effusion in the right lower lobe with internal septations. And the radiologist suggested that we shift the child for an immediate CT. And an immediate CT was done, and it showed a large air-containing cyst with septations in the right hemithorax, with air fluid levels noted in the basal segment. And the possibility of CPAM type 4 with complicated infected hydropneumothorax was given. And there was also passive collapse of the right lung with mediastinal shift noted towards the left. And after that, the child, this is the CT of the child. We can close up view below. And after that, pediatric surgery opinion was obtained and the child was taken up for emergency surgery. The right upper and middle lobectomy was done and the post-operative period was uneventful. The histopath report revealed cysts lined by the cuboidal epithelium and no cartilaginous platelets were noted in the cyst wall, and it was suggestive of CPAM type 2. And a whole exome sequencing was done and it was normal.
At what point did you decide to do whole exome sequencing?
So after, I mean, only after the child, the post-op is when we did it. But
why did you do? I mean, your radiological differential was a CPAM, right?
Yes.
Why did you decide to do whole exome sequencing here? I don't understand that. Is it because it was a poorly responding pneumonia? You thought of something there, or?
So to have a genetic confirmation, because CPAM is associated with DICER mutation.
So it is.
No. CPAM is generally not monogenic. It's not like you find one mutation that is going to tell you this is CPAM. Okay. CPAM is basically a histopathological diagnosis. There are radiological clues to CPAM, but the diagnosis of CPAM is histopathological. There's no genetic diagnosis of CPAM. You did a genetics for CPAM or something else? That is what I wanted to know here.
For CPAM and to rule out any other associated anomalies.
Generally not required.
CPAM type 2 is usually associated with other anomalies also. What anomalies is it associated with? Usually renal, cardiac, those things are more common with CPAM type 2.
We came to a final diagnosis of a right lobar pneumonia, congenital pulmonary airway malformation type 2, and a post right upper and middle lobectomy.
Right lobar pneumonia with an underlying congenital CPAM that was infected now
Yes, ma'am.
with post status post lobectomy.
Yes.
Okay. Usually, how do CPAMs present?
Ma'am, depending upon
Start
the
from
type.
antenatal.
Ma'am.
Start from antenatally. I don't know how it presents antenatally, neonatal, infant, and maybe an older child.
Type 0 can even present with antenatal hydrops fetalis, or you can have
Even your type 1 and even type 1 and 2 can cause hydrops fetalis.
Fetalis. Otherwise, it might present with polyhydramnios because of the airway secretions.
Most of the CPAMs can be picked up in your anomaly scan
Anomaly scan.
in the second trimester itself. Okay. Yeah. So there are 5 types: type 0, 1, 2, 3, 4. 0 is the most lethal because because the cyst is arising from the bronchus itself.
Bronchus and trachea.
Yes.
And
Type 1 is the most common.
Yeah. Type 2 is type 4 is more associated with malignancy like pleuropulmonary blastomas.
If it is asymptomatic like this child, okay, and if you had detected it earlier, what would you have done? If you knew that this was a case of CPAP.
Surgery is recommended, ma'am, even but after stabilization. In this case where there is a complicated infective CPAM, therefore the child is taken up for emergency surgery. But even in a case where we have detected it accidentally also, we should plan for surgery.
By?
1 year.
1 year of age.
Okay, usually 3 to 6 months of age is the best age, but if it is asymptomatic, you can wait up to 1 year.
1 year.
But it's better to operate earlier so that the lung development is better. The expansion is better. Yeah, why should we remove it? If it's not causing any issues, if it's asymptomatic.
It will cause atelectasis of the surrounding lung, and the development lung will have hypoplasia otherwise.
Yeah. Also, it's prone for malignancies.
Malignancy, and prone to infections and complications.
So, see, generally CPAM is a continuum, okay? CPAM doesn't mean it's a huge cyst, okay? We do CT for different etiologies and find out there's a small cystic CPAM-like lesion in the lung, okay? So, there is some amount of controversy about surgery for everybody. The 2 definite indications for surgery are if there is compression. So, you have a neonate who has persistent tachypnea, there's a CPAM, 100% surgery. You have a child who has an infection at the CPAM, like the one you have. There's no argument there, needs surgery. So the other cases where there's a small cyst in the lung which persists, okay. Most of the antenatal lung cysts, they regress. If you speak to a fecal sonologist, they'll tell you most antenatal lung cysts regress. Those which persist, where there's no obvious lesion on the X-ray, child is completely well, there is still a case for conservative management. Okay, so for example, say there's a 1-year-old who's completely asymptomatic till then. There's a small cyst there. The parents are going to ask you, do we really need to do a thoracotomy? Because my child is completely well. So you just explain them the risk. There is a chance of infection. Once there is infection, the surgery is going to be a bit more difficult. Okay, and 2, there is a small chance of malignant transformation.
Malignancy.
So it is up to the parents to decide if they really want to get operated on.
Okay, your final diagnosis should include everything. So also you have to put the other complications associated and anemia also, no? Nutritional anemia. Okay. Yeah. Very nicely presented. Very nicely
well worked
prepared
up case. A very well worked up case. I mean, personally, I don't think I would have diagnosed CPAM at this point of time. Ultrasound, they told me there's some cyst. I would say there's probably some necrotic pneumonia which is appearing like a cyst. I wouldn't have evaluated completely, but it's a well worked up case. Pretty early diagnosis and pretty early treatment as well.
Excellent presentation, Meera.
Thank you, ma'am.
And Sharma, you answered all the questions asked by the experts.
Thank you.
Jacqueline, ma'am,
Yes.
do you have anything to guide the students that how they should present it in your university exams? What are the most expected questions in pneumonia?
Ma'am, always go with the basics. Okay, whatever case you get, it might be a congenital malformation, it might be anything. Go with the basics. Know the basics first. Start with the history. Write each and every point. Everything has a correlation. So start with the basics. Start with the history, presenting complaints in detail. Then nutrition, the antenatal history, natal, postnatal. Talk about the nutrition. Talk about development, the Kupusomic classification, the family history. Give a very good summary. The summary should include everything that you're thinking about. So include everything, and then at the end of your history, you should come to 2 or 3 main diagnoses, whatever you're thinking, 2 or 3 differentials, and you should give points for and points against. Why you are thinking this and why you're not thinking. What is for and what is against it. Your examination also should go correlating with it. So if you have missed something, for example, you found something in examination, so then go back to the history and take that history again and include those points. Okay. And when you come to examination, general physical examination, first talk about the level of consciousness of the child. How is the child? Is the child sick looking or is the child active, alert? So that gives you an idea whether it's bacterial, whether it's viral, whether it's a chronic lung disease or something like that. And general physical examination, each and everything. See, pallor, icterus. Okay. See, that should go according to your case. Okay. So simply don't write pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. There's no point of writing everything. According to the case. In a respiratory case, what is more important? Pallor, yes. Cyanosis, you should always comment about cyanosis. You should talk about clubbing. What does clubbing indicate?
Chronic hypoxia can
Chronic
also be there in
gives you an
some
idea
acute
that-
cases, ma'am.
Yes, something is going on in the child. Lymphadenopathy, then edema. Talk about all the vitals in detail. Heart rate, is it normal? Is it increased? What is the respiratory rate? Is it increased? Is it normal? Is it associated with retractions? What is the saturation? Then you come to the exam. Whatever you feel in the general physical and the vitals, then start with the systemic examination. Come to that system first and everything in detail. Okay. Yeah, that's it I can say.
Thank you so much, sir. Manoj, sir.
I think is this chest deformities. Okay, chest deformities. You have pectus excavatum. You have spinal deformities. You have rib anomalies. You have a Harrison sulcus. You have underlying malnutrition. All these indicate that there's some chronic thing going on in the child. It may not present, but it might be going on. So everything should be spoken about in detail. If probably you had percussed this child, you would have got some other finding. You would have been able to put one more differential. Okay. So rather than telling child is not cooperative, maybe when the child is sleeping, make some time and go. Be comfortable with the child first. Play with the child. Be comfortable, and then you will be able to assess in detail. Okay, and then just because you're seeing respiratory doesn't mean you should leave out the other systems. Even those are important. You should check for cardiac. Maybe there is an associated myocarditis. Maybe there is an associated cardiac disease. You have to check for each and every system. Okay, and then you come to the final diagnosis, each and everything. First, what system you are thinking about? What is your diagnosis? What are the anatomical, pathological, etiological diagnosis? What are the complications associated? What are the other things? Is there malnutrition? Is there incomplete immunization status? Is there anemia? Is there some other problem? So everything should come in your diagnosis. Also write few points about investigations and management plan.
Thank you so much, ma'am. Thank you so much. Manoj, sir, what would be your advice to the students to perform well in exams?
I think Dr. Jacqueline had explained in detail about the case presentation and all those parts. The only thing I would like to add is when you discuss what has happened to the child, it should be in a sort of flow. It should go in a flow. Okay, came with this, we started this happened. That is why we did this, following which we found this out. Okay, so that is what the exome sequencing didn't really fit in with the narrative. You are telling me, okay, the child had a poor response. We did an echo. Incidentally, we found a cyst. We were evaluating the cyst. We diagnosed a CPAM. We did surgery for the CPAM. Okay, so that is your flow. Maybe you would have done maybe there would have been some issues in the management which would have prompted you to do a genetics. Okay, it doesn't fit into the flow. So don't put things that don't fit into the narrative. Other than that, you are very confident in presenting.
Yeah, they were so good. They were so good.
Yeah, you've
Actually,
answered all questions well.
Yeah,
Everything was
yeah.
well prepared. Even
Excellent.
workup of the case is very nice.
Excellent. I have one more to add. Actually, did you classify this pneumonia, Meera?
Ma'am, IMNCI classification, the child came with severe pneumonia, ma'am.
No, in your diagnosis. So, according to ARI program or in IMNC, you have to classify, right, whether it is a severe pneumonia.
The child came with a severe pneumonia,
Did you
ma'am. The child
classify it?
had cough, fever, and chest retractions, along with warning signs like lethargy and refusal of feeds.
So, it would have given an extra edge had you done that.
You can also write with mild distress, moderate distress, or severe distress. You can add that in your.
Child had severe distress requiring ICU admission.
Yeah, so we could have classified. And one more, your antenatal ultrasound at 21 weeks did not show any anomaly, right?
No, ma'am. We saw the records. There was no anomaly. It was given normal only.
Suppose had it shown, will you give anything to the mother?
We have to advise the mother and we have to prepare her regarding, and we have to make sure that she has an institutional delivery and that the child is evaluated from birth, ma'am.
Any drug. I think, madam, is there any role of steroids, sir and madam?
Antenatal corticosteroids, yes, ma'am.
Yeah.
There are some reports
And also,
where it shows shrinkage of these lesions, yes.
Yeah, sir?
Routinely recommended, madam. There is a role though. So generally most lungs is regress. So in antenatal, you cannot differentiate CPAM or bronchogenic cyst or whatever. Okay. You can say an intrathoracic cyst or a lung cyst, congenital thoracic malformation. So most of them regress. If there is high drops, now they're doing cystoamniotic shunts. They drain, they do cystoamniotic shunts. In cystic, so they split into cystic and solid thoracic malformation. Cystic thoracic malformation, your only therapeutic option is a drainage. Whereas in a solid thoracic malformation, there is some role for steroids, although not 100% effective.
Thank you so much. I think they did the whole exome sequencing to know the malignant potential.
Yeah, sure, ma'am. That is why we did, ma'am.
So that is
the tissue diagnosis was kind of confusing. The pathologists are telling initially type 2 and then type 4 something. Mainly to rule out malignant potential. We have, and even the genetic people, they are not convinced. Yeah. Actually, they are also, I talked to them twice or thrice. Mainly to rule out the genetic potential, we did the whole exome sequence.
Actually, the chances for pleuro PPB will be more if there is some gene mutations. Because I'm not sure of the gene though. Maybe that is why you did the whole exome sequencing.
Yes, ma'am, sure. Mainly we asked for only that one, that malignant.
With the experts here, I want to ask one doubt of mine. So previously, when I was a postgraduate, they used to teach us that upper lobe, there is some predilection of organisms for each lobe involvement. So if it is an upper lobe, more likely to be Klebsiella or gram-negative. Is it valid?
If you are competent child, you are unlikely to get gram-negative, madam. Gram-negative only in immunodeficient.
And also age less than 3 months.
Age less than 3 months.
Less than 3 months, yes, we can have gram-negative. Yes, and we have not seen such a right upper lobe pneumonia in community acquired pneumonia, right, sir? Most of them, they involve either the lower lobe or the middle lobe. So upper lobe, if it is involved, have you seen community acquired pneumonia? So it is a doubt form.
Yeah, we have
Is
seen.
that common? Is it that common? So whenever I see upper lobe pneumonia, then I suspect some anatomical abnormality or something else. That's what I'm asking. It's my doubt.
Not like that, madam. Right upper lobe pneumonia happens. Just because it's upper lobe, previously, when I was doing MBBS, upper lobe means TB. So the upper lobe thing.
Upper lobe means Klebsiella when I was a postgraduate.
that is no longer the case, madam.
Yeah, even mycoplasma, as you said.
Wherever the pneumonia is, if it's typical, probably pneumococcus.
So, but so far in this 15 years, I have seen so much of middle zone and also lower zone than the upper zone. That's what I'm asking you, your experience.
We have
Ekambaranath sir, your concluding remarks, and you should be very proud of your students. They had done extremely well and I had answered all the questions.
Yes, ma'am.
Sir, please, your concluding remarks.
Sure. Actually, thanks very much for the opportunity, ma'am. So and luckily we had this interesting case to discuss. RS system. Last time also we discussed only pleural effusion. I think it was some tuberculosis something. Sharath was coordinating.
Oh.
Actually, thanks for the
sir.
opportunity, man. I will convey the regards
Thank
to
you so
our
much.
director also. Thank you.
I saw that they are second year postgraduates, but they are wonderful.
Yeah.
Wonderful.
Yeah.
Wonderful.
Yes, in the final year, so they're going for the exam. Exams are going on.
Yes, sir.
And
Yes,
the
sir.
first
Yes, sir.
year still
It
not
was a
yet.
very
So
short time,
still
actually.
we brand them as yes, ma'am.
Within that
So
short
they still
duration of
consider
1
second
week,
year only. Actually, they are final year.
hats off.
Yes, ma'am. So it, the work also was quite busy. Only the 2 batches are there, and the
Can
season,
understand.
lot of respiratory is coming now. So like they prepared well. So congrats to them, both of them.
Thank you, sir.
Thank you, sir.
And thanks for the
Narmada
mentor. They
ma'am.
discussed very well, ma'am. Jacqueline ma'am and Madhu discussed very
Thank you
well.
so much, sir.
It was
a very
altogether
nice
an excellent
discussion.
session. Ma'am,
Thank you.
Yeah, it was a very
Thank you,
excellent
ma'am.
session, and they presented very well, and it was very interesting to see how it evolved. So very well managed, sir. So one of the
I was
other
thoroughly
things,
enjoyed.
yeah, I really thoroughly enjoyed. One of the other things I wanted to tell the young postgraduates, because after this you will be taking up, most of you are going for your MRCPCH. So in Indian type of examinations, your diagnosis stops and your management stops from here. But whereas in MRCPCH, you will have to be very much clear about how do you counsel the parents. How do you tell them about this thing? See, because madam was repeatedly asking about the antenatal scan. So it is highly possible that they will ask you about the same from the parents. They will want to blame the, the scan. There's a lot of legal implications. So you should know the counseling part of it. Second thing, you should know how you are going to support them in their real daily life setup, because you need to have, they will ask about the real school activities, how much you can support after the lobectomy. So you have to be in, when you prepare for your membership exams, the care after this is very, very important. So when you prepare simultaneously for your MD and your membership, make sure that your thing doesn't stop with there, and you go ahead with the care after this also. So it will be easy for you to clear the exams that day.
Thank you, ma'am.
Excellent point well made, ma'am.
Thank you.
Meera, what did you learn? Sharma, what did you learn today?
Okay, Kritika, thank you. I'm just leaving. Bye.
Thank you, ma'am.
Thanks
Thank you
for
so
the
much.
opportunity.
Thank you so much.
Thanks,
Thank you so
Manoj
much.
and Jacqueline did a very great job, and Meera and Sam. It's very, really nice. Very nice. Bye.
Thank you so much,
Thank
ma'am.
you, ma'am.
It was an excellent session, ma'am. Meera, what did you hope you learned a lot?
Yes, ma'am.
Yeah. If Singaravelu sir, are you here, sir? Okay, shall we close the session, ma'am? So
Yes,
I wish to thank Jacqueline ma'am for your excellent coordination and excellent guidance of the students, and I thank Manoj Madhusudan sir for the excellent discussion, and Meera and Sharma for an extraordinary presentation and discussion. And thank you so much, Ekamparannath sir. Rajkumar sir, thank you so much. And shall we close the session, ma'am?
Yes, thank you
Thank
so
you,
much
ma'am.
for the
Good night.
opportunity, ma'am. We
Thank you
really
so much.
enjoyed moderating the session.
Yeah, you are welcome, ma'am, and you will be called more.
Thank you, ma'am.
Thank you so much.
Congratulations,
Thank you so
guys,
much
and all
for
the
the
best for your
opportunity.
exams.
Thank you, ma'am. Thank you so much, ma'am and sir.
Thanks a lot, ma'am. Thanks a lot for inviting me.
Thank you, ma'am.